Well, good morning, everybody, and good morning, hardcore ASMS members. Thank you for coming out today to honor actually two very important people when it comes to maxillofacial surgeons. The first is Dr. Kazanjian, who you will hear a little bit more historically about from Dr. Gosain in just a few moments. Obviously a giant in maxillofacial surgery and very important in training the current and former generation of craniomaxillary surgeons. But even more important is keeping on that tradition with Dr. Arun Gosain. Dr. Gosain is our Kazanjian honorary lecturer this year and was chosen based on his academic prowess, more than 250 peer-reviewed articles, which I think is unique and outstanding and certainly in my hands unattainable. But also the impact that he's made on mentoring the next generation of maxillofacial surgeons in a kind and caring way, and also in using his significant talents and knowledge in maxillofacial surgery to bring along and continue the excellence in our specialty. So without further ado, I will welcome Dr. Gosain to the stand. He is going to be talking about something that we all care very deeply about, and we're looking forward to your lecture, Dr. Gosain.
Well, it's a tremendous honor to be giving the Kazanjian lecture, and certainly I'm nowhere near Kazanjian, but I just want to remind everyone who Kazanjian was. As I look out over the room, it's mostly my good friends. It was like that at my lecture yesterday, too, so that's one group you can always count on. I know there's a lot of things going on, so thanks for being here. The Varsted Kazanjian was an Armenian-born gentleman. He escaped from Armenia at the age of 16 during the massacre in the Ottoman Empire, and they came to the United States. He was a graduate of the Harvard Dental School, and he then became known after his prowess as a dentist when World War I started as the miracle man of the Western Front for his pioneering efforts in taking the dental principles to maxillofacial procedures. At that time, there was no such specialty as, quote, plastic surgery. He then went on, continued to make these more formalized as the specialty evolved, and you'll hear more about that at the AAPS Centennial Meeting, starting with the association. He then became the 16th president of the association, even though he was a founding member, and I'll tell you why there was a little time before that happened. He was the third president of the ASMS in 1949. He established the dual degree requirement for ASMS members to be dually degreed in oral and maxillofacial surgery and plastic surgery. At that time, there wasn't a clear definition of what was a plastic surgeon. It helped to get our field off the ground in formal training. The paradox is that he was never accepted by the Boston general surgical community because he was not an insider. And that becomes the challenge for which I'd like to address for the rest of the lecture. How far have we really progressed towards diversity and inclusion since the specialty of Kazanjian? So I'm going to take a theme, and Jim Zins had done such a great job at his association talk on defining success, and we all have our own way of looking at that, so I'm going to start with that theme as well. What is career success? All of us in medicine are here because we want a successful career, but who defines that and who makes the final judgment of who is and what is successful? I'm going to posit that the final judgment of your success is made by the patients you choose to serve. We often get waylaid or pulled aside for some other reason, but for the patient, there's no such thing as a minor operation. For us, we might think, okay, we're doing a little ditchel or a lump and bump. That's not the way a patient or a parent's child sees what you're doing. So every single patient is just as important as the next. The next question is the long-term impact of a successful career. That's not something that we define, but it's something that we can have. And the impact on our specialty, as you know, is for many of us research and innovation, and the inspiration and mentorship that we can give on early career surgeons. So I think all those should be measured into if someone else is going to judge success. So I'd like to start with the first step in career development is what is the patient population that we wish to serve? I'm going to take some patients that I've been exposed to, starting on the left side, a girl adopted from China with a cleft lip. On the right side, a young girl in Guwahati, India with a cleft lip. The healthcare settings are very different, but the problems are the same. This girl with a cleft nasal deformity, again, if we were to leave her as is, her ability and self-esteem would be significantly impaired. This girl with a post-traumatic nasal deformity, again, society would judge her differently if we did nothing. This young boy with prominent ears, you can think how his schoolmates are going to treat him as he goes through those formative years. This young child with a giant congenital nevus, if this child came to your job interview as an adult, you would certainly see this before you saw anything else. This young girl who had facial scars from a burn or a car bomb that took place in Iraq. Two young people with facial paralysis on the left from Mobius syndrome, on the right from an intracranial vascular tumor. A young girl with right hemifacial microsomia. A young lady with retrognathia and malocclusion. You can see that she will be judged differently if we do nothing. This young child with a left ossifying facial fibroma, it is benign, but we certainly would not want to leave it untreated. This young girl who's extremely bright but presents with frontal dysplasia and orbital hypertelorism. A young boy with Apert syndrome. A young girl with Crouzon syndrome with midface and mandibular recession and has a tracheostomy in place. And this young girl with mandibular hypoplasia, tracheostomy in place as well. A young man who's had his palate repaired, has significant post-palatoplasty midface protrusion. He wants to be a professional musician. So that's the challenge I define. That's our specialty. It's not just intracranial surgery. Then the next step as we mature in our careers, and many of you are at that phase, is what can we do after we've defined the specialty we wish to treat? And that's where we can facilitate the development of other careers, guide young surgeons in defining those careers, and mentor them as they develop those chosen careers. So how can we grow and retain talent in our field, pediatric and craniofacial plastic surgery? We assume that the selection of a specialty within plastic surgery is based on economic factors, and if we like to deny that, I'll show you the data in just a few minutes. And if that were the case, pediatric and craniofacial plastic surgery is an unlikely choice, independent of the patients I just showed you. The question is, what factors can we cultivate and to retain interest in craniofacial and pediatric plastic surgery amongst our young people who really do have that interest when they join us? So if we look at some of the things as to why we choose plastic surgery as a specialty, economic gain, service to humanity, and the needs of the patient, I'm going to contrast those with some of our other specialties. The last three, the affinity of patient population, camaraderie, mentorship, I argue that you could get that in any medical specialty. So if we were to ask why choose a subspecialty focus in plastic surgery in contrast aesthetic and cosmetic to craniofacial pediatrics, economic gain, I put a plus on both groups, but a lower plus on craniofacial pediatrics. But I want to emphasize there's no field in medicine in which we're not paid significantly higher than the median income. If you compare our salary to a teacher's salary and compare the dedication to a teacher, I challenge any of you to say that a teacher is less dedicated than we are. I know Joe has had that specific experience. Service to humanity, I'm not denying that aesthetic surgery serves humanity, but you can see that those patients untreated would be at significant losses in our culture. Correction of a deformity, sometimes the cosmetic patient, we can't always appreciate the deformity. It's clear what the deformity is in our craniofacial and pediatric population. We can improve the appearance of both groups of patients. Self-esteem clearly is improved, because that's a perception of the patient. But social acceptance, again, even though you can say, okay, I'll do better if my nose looks a little better, if it's completely deformed, the society will not accept you. So I then we looked at some data, and some of our residents out here in the audience helped me. We combined this with the Plastic Surgery Resident Council, so we got a lot of data on what residents and students really are looking for. So in that survey, we got responses from about 40% of our institutions that train plastic surgeons and 276 residents. We asked them to rate different specialties that you can see on the right there, with 1 being the lowest, 5 being the highest, and we asked for 3 phases: their pre-residency application, basically the medical students applying to you, during their junior years, which is PGY 1 to 3, and integrated or the prerequisite training in an independent program, or their senior years. So if we look at their academic interests at the time of the application, over 82% of those, that means when they're medical students or telling you during the interview what they want to do, over 80% said they're interested in an academic career. When we asked them, because it was an anonymous survey, 5% said this was just said because they knew that's what we wanted to hear. But in terms of those who expressed an interest in aesthetic surgery at the time of the pre-residency interview, it was about 2%. Then looking at them in their junior years, now they're not trying to impress anyone, they're now trying to figure out what they want to do. We can see that aesthetic, craniofacial, and hand are all on par in their junior years, so we still haven't lost them. Now let's look at the 150 who are now senior residents and reflecting back on the evolution of their thought process. We find that for the entire senior cohort, aesthetic and gender affirmation surgery goes up significantly. The one that goes down the most significantly is craniofacial surgery. And then in terms of the characteristics that they're looking for as senior residents, there's a significant increase in their weighing on private practice, job opportunities, and compensation. And what was disconcerting to me is the desire to emulate a mentor. I didn't care about academia because I know they're going to drop on that, but the desire to emulate a mentor was disconcerting, and I'm going to try to focus on that to some extent. Of the 60 who said they reported a change in interest, you can see that, again, craniofacial suffered the most. It was a 44% drop, whereas aesthetic, as you know, if they went from 2% to who's going into it, was a 143% increase. So and then looking at those 20 who specifically said that they were interested in craniofacial and no longer are, the factors they point out are the desire to work in private practice, the perceived job opportunities and compensation were at the top of the list, the desire to work in academia and the desire to emulate a mentor were at the bottom of the list. So looking at some of their comments, the ones who are leaving craniofacial pediatric plastic surgery, they felt that this field has a lack of jobs, doesn't get good hands-on exposure during training, the likelihood of geographical restrictions limited their opportunities, and there are plenty of surgeons operating into their 70s and 80s, and the egos are unbearable. Those leaving academic practice, again, because craniofacial pediatric tends to be in that academic arena, they talked about administrative burden of academic practice, the lack of the demoralization of physicians because they're controlled by administrators, the unpredictability in their schedules, and if their goals are to provide excellent care to patients, be fairly compensated, and have a good work-life balance, they felt that academic settings had the worst offerings in all 3 categories. Again, this is a biased group because those who already have made that decision. So then the next question I wanted to ask is, what do we do as plastic surgeons? Because that's something I never have been able to figure out. Even the ASPS, when you look at their data, they combine, in the latest data, they combine a survey of 278,000 surgeons, and you don't know how many of those are plastic surgeons. It was only in 2010 where they broke down what the plastic surgeons said about what they do. At that time, which was about 10 years ago, we were doing about 2 million Botox injections per year. Soft tissue fillers, about 500,000. And then if you go to the operative procedures, the most common was breast augmentation, about 280,000. And then if you go down to maxillofacial surgery, 18,000, and cleft lip and palate, 13,000 or 14,000. Again, you can take that 2 ways. One, you can say we're not interested. 2, you can say there's not the market. if we look at the market, again, we don't have the data because the ASPS combines data, but maxillofacial surgery cases, when it was last reported exclusive of facial lacerations, which was 2,000, was 80,000, not 18,000. So there are other specialties doing it. In terms of congenital cases, they didn't break down cleft lip and palate, was 64,000, and I'm assuming that the majority of those were cleft lip and palate. So it's not that the market is not there, it is that we may not be pursuing it. So then, how do plastic surgeons describe themselves? 85% describes themselves as cosmetic surgeons, 16% describe themselves as craniofacial surgeons. Remember what we just said, pre-residency applications, greater than 80% were academic with less than 2% aesthetic. Junior residents, it was an equal interest in aesthetic and craniofacial, and this is what they describe themselves once they are in practice. And then the tracer data, another way of looking at what we actually do. This is what people turn in on 3-year cycles for a 10-year recertification period. We see that over 50%, or about 50% of the tracer cases are in breast augmentation or reduction, and less than 4%, if we add up all the others, are in the craniofacial modules. And I've highlighted in yellow the congenital modules. So the reason I start with that, not is to discourage you, but to define the problem. The problem, if we're going to summarize, is many people see craniofacial surgery as an old boys club. They feel that there's minimal diversity amongst craniofacial surgeons. We've all heard, and I don't want to quote anybody, but I'm just going to bring up the points. We do not need more than 5 to 6 craniofacial surgeons in the United States. Many of you know who said that. Craniofacial surgeons are not interested in promoting their peers, and if you go to the editor-in-chiefs of our major journal, if they're going to point out any group that doesn't support the papers of their other group, it's the craniofacial group. So the next part of my talk is our challenge. What can we do now that we've defined the problem to try to change that? So to start, I think we can each take it at an individual level. Start with mentorship, and I'm going to go back to the fact that that was not valued by those who left. Diversity in trainees is something we would like to address, and clinical innovation. As an institution, we can point out that craniofacial pediatric plastic surgery is critical to the hospital mission, and on a national and international level, we can focus on advocacy and the improvement of global health opportunities. So let's start with mentorship. What do we need to grow and retain talent in our specialty? Certainly we need role models for aspiring trainees, and we need the mentorship of those trainees, proper mentorship for those who express an interest in our field. Remember, the senior residents who transitioned away from this field were the ones to least value mentorship in their career decisions. So somewhere we lost them in those years. If any of you went to Fouad Nahai's talk yesterday at the trustees' talk, it was, where would I be without my mentors? Fouad Nahai put mentorship as the main reason why he's here today. So somehow we're losing the Fouad Nahais who might be contributors to craniofacial pediatric plastic surgery. And this was India over 5,000 years ago. The concept of mentorship is not new. And I'm going to take a triad of mentorship groups in craniofacial pediatric plastic surgery who we've identified as leaders. And I'm going to look at their senior mentor, the mentor, and an established and recognized mentee. Ron Zucker, mentored by Ralph Mangelo. Ron, I think it's extremely important that a young surgeon have support from older, respected colleagues. Training is different now. There are more residents, more fellows, and our interactions are much more complex. Allison Snyder-Warwick, mentored by Ron Zucker. Allison, it's essential to have a mentor that you feel comfortable asking their opinion, even after graduation and even when facing your own complications. The trust also fosters discussions that ignite responsible innovation. John Mulliken, mentored by Paul Tessier. John, I never thought of myself as an inspiration or a role model while working closely with fellows in the clinic, OR, and writing papers. It's just great fun. Joe Murray, a mentor to John Mulliken. John's comments on that. If working in an established unit, which of course you know John started, be patient and consider developing expertise in another or new field. Once you find your dream job, stay in one place and don't wander. Aaron Green, mentored by John Mulliken. Aaron, Choose the area that you're most passionate about, which will help you innovate and stay in the field. It is more important to do what you're passionate about than where you live and how much money you make. Linton Whitaker, mentored by, and again, just to recognize them, if you can see, this is Linton, this is Paul Tessier, this is Peter Randall. Linton inspires students by repeatedly conveying the endless fascination with the problems and the unending efforts to solve the insoluble problems, and always strive for perfection, even while recognizing it will never happen. Scott Bartlett and the mentees of Linton Whitaker. So I didn't want to just show one because many of you are those mentees. Here's Scott. Scott, students are often so attuned to mainstream plastic surgery, breast anesthetic, and they haven't even considered pediatrics. It's in the OR when you can show them new approaches that will pique their interest. Ken Salyer, mentored by Jack Mistarde. Ken, be a pediatric plastic surgeon. Don't feel that you must do cosmetic surgery to make a living. Adult practice should not consume one's identity, but rather foster innovation by applying craniofacial principles to adults. Yurei Chen, who was Ken Salyer's first fellow. Ken, remain flexible and open when considering techniques so that one continues to improve in techniques and outcomes. Akira Yamada, who's here in the audience, is mentored by Ken Salyer. Akira, explain my current thinking or philosophy to students and why I'm doing this procedure. Explain what is achieved so far and what is still unsolved. And I want to recognize Akira for getting numerous teaching awards since we recruited him. Bauman Gairan, mentored by Paul Tessier. Bauman, whether or not they are going to be full-time craniofacial surgeons, a craniofacial surgery experience is going to be colossally helpful. Application of craniofacial principles to the adult population led me towards innovation in rhinoplasty and migraine surgery. It's almost a given, but I was so glad that Bauman pointed that out. Ali Tatanchi, mentored by Bauman Gairan, and again, so many others. You see Jeff Janis and others there as well. Ali, the positive feedback from patients who did not get the best results by previous providers and outcomes from secondary and tertiary cases done by a mentor such as Dr. Gairan had tremendous impact on my career. John Converse, who mentored Joe McCarthy. Joe, follow mentors who are enthusiastic teachers. Do not focus on lifestyle or salary from early career, but ask residents what they want to be doing at age 50. There must be feedback. The mentee must challenge the mentor. Richard Hopper, who was mentored by Joe McCarthy, and he also attributes to Joe Gruss. Richard, during the last year of my residency, the craniofacial cases unsettled me. Their high complexity, the potential risks, and how in many cases the surgeon wished they could have done more. I knew it was a journey on which I would never get bored. Joe Cerletti, mentored by Paul Herrera. Joe, I tell students to be less concerned about other specialties taking away pieces of what we do, but rather focus on new unsolved problems. As plastic surgeons, we have always been the problem solvers for our surgical colleagues. Joe Losi, mentored by Joe Cerletti. Joe, despite what others say, what others think, follow your dream and passion and make it happen. Lester Silver, mentored by Art Barsky. Lester, by and large, I feel that encouragement is given by showing an interest in the student. Peter Taub, mentored by Lester Silver. Right there. Peter, we are frequently consulted for patients that need solutions for problems that others cannot provide. I am amazed at the effect one day in the operating room can have in shaping the career of an aspiring surgeon. You know, a lot of you said this, you may not even remember telling me this, but I have it all written down. Louis Vasquez, mentored by Josh Yurkiewicz. Louis, in the words of Mother Teresa, do not worry if your children do not listen to you. They are observing what you do all day. Residents learn how their teacher handles mishaps, and they learn how to treat patients as they would like to be treated themselves. And then the young Henry Vasquez sitting right there, mentored by Louis Vasquez. Henry, mentoring is best accomplished by example. In the case of Louis Vasquez, he's been able to put together all these essential elements of being a doctor and a humanist. He has been able to put the important aspects of medicine and life into perspective. patient care and care of your fellow man, decency towards all, and ethical behavior, as well as love of family, are what characterize him. So the next couple of points I want to make is just maintain those relationships. Again, we know that the senior residents are not valuing mentorship as much as we might have to enter this specialty. So just as my own example, here's Dr. McCarthy. When I graduated from the fellowship, maybe about 30 years ago, here I am as a young attending in my first 1 or 2 years of practice. He knew that it was going to be an uphill battle to get a practice going where there was already an established practice. So he came and spent a couple of days with us. And then here he is at his retirement. So I would say that here are two super mentors who've followed their mentees over almost a 30-year span. And in the words of Joe McCarthy, the teacher not only intellectually stimulates and supports, but also promotes the transmission of truth and knowledge from one operation to another. And I know Akira would be equally proud of Ken as I'm proud of Dr. McCarthy. Mentorship, the key to recruiting and retaining craniofacial pediatric plastic surgery. We're all here because of the personal time and investment that our mentors gave to us. We need to maintain the continuity between the training period with our own mentors and with the mentees who have sought us out, and develop reciprocal mentorship relationships as those careers evolve. And we want to also look at how the next challenge, as I mentioned on our challenges, how can we diversify our trainees? So start with female membership in plastic surgery. How inclusive are we? These are the latest data from 2019 to 2020. So if we look at the medical school applicants to plastic surgery and the plastic surgery residents in PGY 1 to 3, it's almost 50%. ASPS resident members, again, they're going to catch up, but they're 38%. Candidate members, 32%, as they're a little more senior. Active members, again, even more senior, now 19%. ASMS active members now just under 14%, and AAPS, or association, which is our academic society, just under 9%. So we know that this is going to increase as these individuals filter out into the more senior group. But we'd still have the challenge that can we keep these lower societies, which is craniofacial pediatrics and academic, keeping up with the pace of that recruitment of females into plastic surgery. The expanding innovation, the process has to be active and not passive. We have to encourage diversity. This is the best time to get diversity into our specialty and mentor and support those who demonstrate that interest. So I'm going to just start with my own experience and what works. Here's our lab at Lurie Children's. It's the first exposure of young people to innovation in plastic surgery. Many of them don't know what plastic surgery is, but they know what innovation is. And in fact, if you take all of what we've been ingrained to learn out of our minds, they're just as innovative, maybe more innovative than we are, because we've been ingrained in something. So this is the group, Cultivate the Diversity. You can see that we have gender diversity, ethnic diversity, and the diversity of specialty. We have undergraduates, medical students, residents, and research scientists all in that lab. So it's a one-room schoolhouse, and make them all feel included. Get the young people involved in research and innovation, explore unsolved problems, and these minds will grow our specialty over their careers. If they get committed to these questions right away, then those questions become ongoing drivers of their career focus. Use that investigation to fuel new investigation. Pediatric tissue expansion is the entry to an untapped set of questions in tissue regeneration. And if you ask what's the most common form of breast reconstruction, is tissue expansion. Who knows more about tissue expansion than we do? So we can solve some of those problems and really get into the heart of plastic surgery. And by cultivating investigation, our trainees, the reward and recognition they bring far outweighs the effort you make in developing their careers. We wouldn't have gotten all these awards if it weren't them. I couldn't have gotten it on my own. The Crickler Award multiple times, Snyder Award at the Research Council multiple times. All of these basic science awards at the Midwestern Association this year were to our group, PSF Research Fellowship. So it's really them that has put in that innovation. And then collaboration is something I know that all of you who are focused on research support. So looking at our group at Lurie Children's, We've paired with the group at Stanford, and that was serendipitous. They called us because they wanted to know more about tissue expansion. This was several years ago. This is Ellen Kuhl, who is the head of bioengineering at Stanford. I don't know if you know her, Jim, but been a great collaborator. This young man, Adrian Buganza Topole, then finished his postdoc, went to Purdue, and he and I then are now co-investigators on an NIH grant looking at the biomechanics and genetics of tissue expansion. So that collaboration can develop and it can promote the careers of your collaborators as well as your own. The apply craniofacial principles to drive clinical innovation, and this is something that many of you won't accept, but I think we have to dispel the myth instilled by Pourquoi Pas. Craniofacial surgery is not defined by intracranial cases. The U.S. is not the sole territory of 5 to 6 craniofacial surgeons. Those are the things that I heard when I was entering the specialty. Craniofacial surgery is built on facial anatomy. The true innovators recognize this, and they've applied those principles to drive clinical innovation in whatever application is best suited for that. And the growth of our specialty is driven by that innovation. And I want to give you some examples. Baman Gairan, he did his craniofacial fellowship with Ian Monroe, and he has certainly been a driver of innovation in rhinoplasty and created a whole new field in migraine surgery. Jim Zins, who is right here, did his craniofacial fellowship with Linton Whitaker, used that facial anatomy expertise to apply to facelift, has brought it into a whole new realm with his aesthetic fellowship. Joe Cerletti trained with Paul Manson. Microsurgery does not require a microscope. That was his theme at the Clinician of the Year speech at the association this year, and he's taken that to go on to be applicable to global health. Jim Stuzen, who trained with Henry Kawamoto, he has become a leader, again, in taking facial anatomy, applying it to aesthetic surgery, and he's also taken that to the academic level as his co-editorship of PRS, which has terminated this week. Charlie Thorne, this is a younger Charlie and a younger me, but he, of course, trained with Joe McCarthy. He's gone on to be an expert in microtia, president of ASAPS, and continued to extend the academic realm of a craniofacial surgeon in multiple fields. So the challenge is to make, the next challenge is I'm going to take it onto the institution. We have to champion craniofacial and pediatric plastic surgery as mission critical. So let's look at how the hospital views us compared to a cosmetic surgeon. Central to the hospital mission, they really don't care about the aesthetic surgeon unless they're getting revenues from what that individual is doing. They know that craniofacial pediatrics, if they ever say that that's not central, it will be a significant negative on their image. Financial return to the hospital, again, even though cosmetics has a good return to the provider, it may not have such a good return to the hospital. Our craniofacial patients who are major cases and stay give much more return to the hospital. Potential for philanthropy, it's going to be hard to get a lot of philanthropy for breast augmentation. And that's what most of us do. But you will certainly get philanthropy for the types of patients I showed at the beginning of the talk. And then advocacy. Regional and national advocacy benefits the hospital both for potential increase in hospital revenues, and it clearly enhances the reputation if they're seen as a leader in advocacy issues. So I'm going to give you an example of a key advocacy issue that many of us have worked on, but it's the ELSA, or Ensuring Lasting Smiles Act. It's an act that's looking to extend the Medicare and Medicaid coverage for congenital anomalies to private insurance carriers. And it's taking it out of the state hands into a national federal regulation. And it's asking that all congenital anomalies and their supporting activities such as orthodontics, dentistry, which we all have such a hard time covering, be covered. It was a white hat issue for our society, the ASPS. It was passed on the House floor, but now it has to go for a revote with the changes in Congress before it goes to the Senate. But our hospital then, when I realized that and I could get the hospital involved, we mobilized our Washington team to collaborate with the ASPS. So it was the first time that our hospital and the ASPS have worked together on an issue that they felt was central to the specialty. And it makes our specialty mission critical to that hospital. They're invested in it. So, and I know you can't read this, but it shows 24 specialties have signed on to ELSA. So we're not territorial. We don't have to fight oral and maxillofacial surgery to tell them this is a need we can work on together. The next challenge is make our environment friendly and inviting. Cleft and craniofacial cases, that's why everyone enters our specialty. You can say, okay, you can come to my hospital, but you're doing no cleft and craniofacial cases. I would argue that that person probably would not have gone into craniofacial pediatrics if they knew that at the onset. So, so just consider, I know we're all territorial, we're all proud, but consider that. Consider distributing non-referred cases to all of your faculty members. That provide each member, and again, there might not be enough to say I'm the world's expert on intracranial cases, but give them each a niche so they can have further growth. It can be facial reanimation, vascular anomalies, gender affirmation, microtia. Diversify your faculty. Dispel the myth that we're an old boys club. The residents and students will see that. If you say we're not an old boys club and you are an old boys club, it's going to be transparent. And promote your faculty. We as leaders have the golden tickets. We have to distribute them. So I'm just going to show our faculty here. This is my group at Lurie Children's. Jen McGrath, who just recently finished her fellowship. All of us do craniofacial. Her niche is developing into vascular anomalies and gender affirmation. Akira, of course, his niche is well established as an expert in microtia surgery. Newport, who is now mentoring Jen, even as a young faculty member, in developing the niche in gender affirmation, and continues to be our microsurgery colleague. And then the next thing I want to talk about is global health. We can expand that. It excites the young people about execution of the ideals that drew them to our specialty, and we're not limited by the patient population in developed countries. It serves a global need beyond that of our individual surgeons. So this just tells you that there are over 1 million children who have had unrepaired clefts. Most of them will never eat or speak properly. They won't hold a job. And probably the most important thing in these underdeveloped countries is a lot of them just come to you because they're not going to get married. They need to be competitive. So how can we justify the statement there's not enough work for a craniofacial pediatric plastic surgeon? Here we are in Guwahati. This is Operation Smile. This young child I showed you at the beginning, and you can see how the mother reacts just to see that we can get this taken care of. This is another trip to Guwahati. Don Mackay, you all know, and myself. This is Jordan Steinberg, who is my resident, Kathy Henry, who is Don's resident. Both of them did craniofacial fellowships and are practicing craniofacial surgeons. Chad Purnell came with me to Guwahati the next year, again, craniofacial fellowship, craniofacial surgeon. So what I'm saying is it's a great way to draw people into our specialty, make them realize how much we can accomplish. It serves the patients who drew you in. We have to cultivate diversity and continue to follow your patients. So the final chapter, let's reevaluate the patients who drew us into the specialty in the first place. How does our treatment impact their lives? And can we really justify shifting our career focus elsewhere based on their needs and what we can do for them? The young child adopted from China with cleft lip repair. Here she is at about age 11. She is now on the sizzle reel of ASPS. This young girl with the cleft nasal deformity went on to develop multiple support groups for children with clefts. She has raised significant funds for Operation Smile, was a patient of courage by the ASPS. Post-traumatic nasal deformity, she can now be acceptable in her school. This young boy with prominent ears should not be teased as he's growing up. The giant congenital nevus, it's not going to be the first thing you focus on when he comes for your job interview. The girl with the facial burns, at age 6 years and at age 16 years, you can see how much of a difference it makes. She spoke to us at the ASPS opening ceremonies in 2018, if any of you remember. So she's a high-impact young girl. Left facial paralysis from Mobius, following her over greater than 20 years. She now works for an insurance firm. Young boy with an intracranial vascular tumor, he can go to college with the confidence that people won't judge him for his smile. Hemifacial microsomia, 10-year follow-up. People would not notice that her face was deformed as a child. The young girl who had the retrognathia and malocclusion, can go with confidence onto graduate school and business. The young girl with the ossifying fibroma of the face certainly will need to follow her, but she will not draw that same attention when she goes to her classes. The very bright young girl with frontonasal dysplasia and orbital hypertelorism is now not singled out for her facial appearance. The young boy with Apert syndrome can have a normal facial profile in his school. The young girl with Kazanjian syndrome who came with a tracheostomy, after advancing both the midface and the mandible, were able to get her tracheostomy out. The young girl with almost no mandible, we've given her a mandible. She has intrinsic pulmonary pathology, so she won't be decannulated, but she can at least present with a more natural face. The young man with post-palate midface protrusion wants to be a professional musician. He now is pursuing his dream. So again, what are our solutions to reinvigorate craniofacial and pediatric plastic surgery? At the individual level, I want to stress that we can provide mentorship, we can look for diversities in our trainees, and we can make them geared into clinical innovation. What about the institutional level? We can show our hospitals that our service is mission critical, and they're going to have a hard time arguing against that. What about the national and international level? We can get them involved in advocacy. They should be advocating along with us. It's not an individual effort. And what about global health? There's no question, Jim Chang's here in the audience, that that's really a key component of our growth over time. So I bring this, this is one of my favorite slides from when I was in Kochi, Shishruta, and he was the first recorded rhinoplasty, the first cleft lip repair, the first forehead flap, the first otoplasty. When did it take place? 2,600 years ago. So that's innovation. But my next question is what happened in the next 2,000 years? It wasn't until Tagliacozzi that we started seeing plastic surgery as a specialty. So what I'm saying is that don't omit mentorship. And it's not for me to criticize Sushruta, I don't know what happened, but somehow the mentorship did not take place. Then I want to conclude with one of my proudest achievements as the ASMS president, past president and head of the nominating committee. We have 73 male presidents, 1 female president. I'm proud to say that I was on the nominating committee when we suggested that first female president, and she's your president today. Thank you.
Thank you, Arun. Great talk. One of the best talks I've heard this entire meeting, for sure. Before we go through with the ceremonious part of today's lectureship, are there any comments or questions? We do have a couple of hot mics. Or if you just, since we're a small group today, you just want to shout out any sort of comments or questions for Dr. Gosain.
Hey, Arun, thank you so much for this very inspiring lecture. In the slide was spreading the unassigned cleft cases to all. Do you include the ODO and OMFS people?
No, just the people in our division. So again, yeah, I'm not going into scope of practice and territorial. We're not here to promote OMFS. They'll promote themselves, but we are here to promote those who followed in our footsteps.
Thank you.
Well, thank you all for your listening and for your attention.